right, good evening, everybody. And my name is Lena Caton. I'm at University Hospitals in Cleveland, Ohio. And I'm one of the co-chairs of the Bariatric Committee for American Foregut Society, along with my esteemed colleague, Dr. Barham Abudaya, who's at the Mayo Clinic. And we're really excited for a wonderful evening here tonight. We're going to be talking about GERD and obesity and what to do. And the really exciting thing about this is we have some really cutting edge ideas that we're going to talk about. As you can see from all the faces that are on the screen, many of them are well known in this space. And I look forward to some really exciting talks and discussions and you know, a wonderful hour and a half. We have several people on the screen right now. We'll have a couple of our other panelists joining us here shortly. And we're going to start this off with a really exciting case. We talk about how to manage GERD and obesity, and there are panels at every meeting that you go to nowadays. And Dr. Abudaya and his team have come up with a really unique approach that they're going to share with us here. And then we're going to have all our panelists discuss kind of their case and how they went around it. And then we're going to follow this with some rapid fire lectures. So for our first case presentation, I'd like to introduce Dr. Barham Abudaya.
Thank you, Lena. It's a pleasure to be with you, colleagues. We have a panel of superstar colleagues and faculty who will discuss this case. It's really, the topic is very timely. This is the intersection between obesity and GERD is a big, significant unmet need clinically. And we're all trying to figure out how to best respond to such a prevalent combination of chronic diseases with the different approaches that we have. Without further ado, I would like to present the panel quickly, and then we'll start the discussion. We have from Brigham and Women's Hospital, Dr. Pishimol Jarapino. Welcome. We have from Mayo Clinic in Florida, Dr. Vivek Kumbari. We have from University of Michigan, Dr. Alison Schulman. We have from Cornell, Dr. Reem Shariha. We have Professor Nathan Zondel, who is a world expert in bariatric surgery, and we're very excited to share the floor with them. We're awaiting Dr. Christopher Thompson from Brigham and Women's Hospital, and unfortunately, Dr. Manuel Galbao Nieto. He's stuck in Istanbul as usual with his travels, and he will not be able to join us. So without further ado, I'm going to share my screen, and we're going to start discussing the case. And we have some really interesting videos to go over as well, and we discuss the case together. Before we start the case, do we have an okay on the audio and visual? All right, great. So the case is of a 38-year-old female with class 2 obesity, body mass index of 38. She has chronic heartburn and regurgitation as a predominant symptoms of gastroesophageal reflux disease. She had them for years, and they're affecting her quality of life and quite bothersome symptoms. She has past medical history of depression, managed well on SSRIs. She has also medical hypertension and managed on hydrochlorothiazide and lisinoprols. She does smoke 1 pack per week. She drinks about 2 to 3 alcoholic beverages per week. Family history is non-contributory as far as there's no family history of esophageal cancer. And she tried multiple different PPIs with different over-the-counter and prescription varieties, and she just cannot tolerate PPI because she develops this refractory diarrhea on the PPI. So this is a real patient, a real scenario. And now the question is, what options do we have for such a patient? And I will open that. Maybe we'll start with Dr. Gerpinio to comment on the case and give us some thoughts.
Oh, thank you so much, Dr. Abudaye. So I probably would start by asking her, since she cannot tolerate PPI, should we try, I assume she tried S2RA, and she probably like continue to have symptoms, correct?
Correct. She tried H2 blockers and not enough symptom control to improve her quality of life.
Yeah, so it sounds like she is basically failing medical therapy for reflux. So I think the next step would be usually I would kind of approach from an endoscopic approach and then start discussing with her, oh, your BMI is 38. So usually I would offer to her two options. Number one, we can consider doing a combined approach where we treat both obesity and reflux in one procedure. Or alternatively, we can consider doing a two-step approach where we do an anti-obesity procedure and see if weight loss will help with her reflux. And then if she continues to have symptoms, then we can consider doing an endoscopic anti-reflux procedure. But then one caveat from the history here is a smoking history. Usually for patients with active smoking history, I would try to advise her to stop smoking for at least 3 months before we doing any anti-reflux or anti-obesity procedure.
All right, all excellent points. For the sake of keeping the flow going, so you suggest that we could label the patient as refractory or intolerant to medical therapy, and now we're looking at surgical versus endoscopic options for managing her disease.
Correct.
So before we jump to this, we'll give you more information about workup to kind of steer the clinical decision making one way or the other. She did have a pH Bravo of PPI for 48 hours. Quite moderately high Demeester score. That means she's truly symptomatic, 44, with correlation with symptoms. She had a 2-centimeter hiatal hernia. There is no Barrett's esophagus or esophagitis on EGD. Her Hell valve is 3, actually early 4, because it's a small hiatal hernia, but it's between 3 and 4. And GE junction is at 38 centimeters from the incisors. And given that we were contemplating bariatric surgery, we checked a high resolution manometry that showed ineffective esophageal motility. So Dr. Zendel, with these variables, any favorable options at this point?
Yeah, you see, she has something that is very relatively easy, very relatively complicated, because it's very easy to understand that she's a candidate for a bypass from every point of view, except one, that is she smokes. So, and that make it very complicated for us to do anything surgical. Second, we know that doing a sleeve, at least in my personal opinion, to a patient with this reflux will be something very wrong to do. So I don't disagree with the concept that she probably is gonna need 2 different things. Good thing she doesn't have diabetes, because if not, the problem will be even more complicated, because bypass will be totally indicated. But with this smoking, I don't disagree in thinking in doing something endoscopic and see how it goes. But you see, either endoscopic for the reflux or either endoscopic for the obesity. And that probably is the important discussion here. Are we going to do something endoscopic for the obesity problem, or are we going to do something endoscopic for reflux? That will be the most important discussion for me.
Okay, excellent points. Dr. Schulman, does the finding of ineffective esophageal motility sway you one way or the other picking between endoscopy and surgery, or it's a minor finding that could be due to reflux?
Yeah, that's an excellent question. I don't know that we have quite enough information yet to be able to determine that, but I think it would be maybe not the best decision to consider a surgical intervention with ineffective esophageal motility, as that can also be worsened by some of the surgical procedures. I think that I'm liking the endoscopic approach at this point, and considering both a weight loss procedure and a reflux procedure simultaneously.
Thank you. All right, so let's keep moving. I would like to focus on the technical aspects because we have experts in both techniques here, and I would like their opinion as well. So it's very important to highlight the complexity of this case. We're not just dealing with a defective anti-reflux barrier, which is made from the flap valve of the intra-abdominal esophagus, made by the diaphragmatic crust, and of course the lower esophageal sphincter. We know that this complex in this patient is defective. So we're looking at a repair for that, but also we have to be cognizant here that she has obesity with increased abdominal pressure. That means any repair of this anti-reflux barrier is prone to failure if we don't deal with the obesity. Therefore, nobody's jumping about offering this patient a Nissen fundoplication at this point because we know that the risk of failure is high. And she has some potential confounder that her esophagus is not clearing very well. Albeit she does not have a major Chicago classification of a motor abnormality, she does have an effective esophageal motility that we don't know if it's in the setting of reflux or not. And she smokes, as some of the colleagues suggested, Roux gastric bypass could be a good option, but the smoking might be a confounder here. And the fact that she does have a defective hiatal hernia also could make gastric bypass an issue, but we'll have plenty of opportunity to discuss that. So without further ado, we started here with the paradigm of given the complexities of the case and the nuances, we said we're going to try the endoscopic approach, and we started with the two-step paradigm of that approach. That means we started with a GERD management, and then followed with a concurrent bariatric intervention in order to attack both components of the pathophysiology, repair the anti-reflux barrier, and improve the obesity in order to have better outcomes on GERD. So the treatment here was for GERD rather than for obesity, but given this interaction between these two disease processes, we thought this would be a reasonable option. So the first intervention that we embarked on is this transoral incisionless fundoplication. And just to level set the audience, in case people are not familiar with this procedure, basically it's a transoral procedure that creates a 270 degree flap valve around the GE junction by elongating the intra-abdominal esophagus and having these rotational forces in order to create the fundoplication or create a wrap between the cardia and the elongated intra-abdominal esophagus to create this flap valve. Now, this valve is anchored by a set of 1,0-proline T tags, or tags as what we call serosive fuse. These distribute the force in order to maintain the integrity of that wrap and to induce fibrosis that will maintain the configuration over the longer term. So that's what you're going to start seeing in the first portion of the procedure that we're going to be seeing right here. So we started with this procedure, and now I would like the experts to start commenting on technique. I know Dr. Sharaiha was probably the first one to report this combination. So Dr. Sharaiha, so how would you start the TIF procedure in this? Anything special? Do you do it in the standard fashion? I'm going to keep the video playing, but I would like you to comment on the technique.
Yeah, I would. I definitely would start with the TIF over any endoscopic option for obesity, because you want to make sure that the valve is as close as you want, and you want to have the room to be able to do that 270 wrap. I think even though you're worried about the tightness of the valve, you can still get any of the regular devices through either the Apollo or the Pose device, if that's what you end up choosing.
So now talk to us about this. What are we doing here? We're at the 11 o'clock angle of trying to wrap posteriorly. And we're trying to elongate here as we're pulling. We're trying to get a 3 centimeter intra-abdominal length. And as we're elongating with the helix engaging at 11 o'clock, we're doing this rotation to create the wrap and then fire. Anything else that you would do special, or the standard TIF is sufficient here?
I think the standard TIF is sufficient. What we end up doing is we use more fasteners. I think when we were taught TIF, I want to say 5 years ago, we would probably use 20 fasteners or probably less. And now we're sort of moving on towards using 22, 24 fasteners and sort of re-looking at the valve, especially at the what you showed, the 11 o'clock and the 1 o'clock position, to ensure that the valve is tight, and sort of not being afraid of tightening it as much as you can or rotating as much as you can. And you see here that you have a good length of the valve, and that's what we want to aim to do. I sometimes turn off the CO2 to ensure that you get as much suction. When you turn off the invaginator as well, that helps as well, and just ensure that you grab as much tissue. What's interesting is that all these devices, both for weight loss and GERD, have the tissue screw helix that ensures that you get full thickness plications or durability. So it's important that you learn how to use that and utilize that well, because that ensures the durability of your procedure.
Barham,
yes,
I have a couple of questions for the expert specifically for this. So what will be the limit size or the limit of the heel classification that you will go to use TIF? And also, if obesity is a relatively contraindication to do TIF. So that will be my two questions.
yes. Dr. Kumbari, would you like to address these questions?
Yeah, thank you. So I'm going to start with the second first. Obviously, it'd be nice if the patient did lose weight prior to this procedure. I think it's going to benefit them in a multitude of ways. As far as I'm aware, it's not a contraindication. TIF has been done sort of in BMIs sort of above 35, but and with the lack of other conceivable options, I think this is reasonable. You know, the other endoscopic weight loss approaches, you know, ESG, intragastric space occupying devices like intragastric balloon, etc., wouldn't be possible. You couldn't do them and then do an immediate TIF. There just wouldn't be enough space there. And your and I think your other question about, you know, is having not got to the root cause of the problem by treating obesity, is this sort of a setup for failure? You know, I think that's a reasonable question. In light of any other sort of suitable alternatives, you know, this might be reasonable, although I'd also be concerned. And then the hiatal hernia, I also found a little interesting. Sort of Hill 3 and a 2 centimeter hiatal, the 2 centimeter hiatal hernia, I think is a go for TIF. I wondered about the Hill 3. I'm relatively early on in my TIF experience, and I've sort of kept it to hills of 1 and 2. So I might defer that to someone else, but I think it's worth addressing. Yeah.
So I thank you for these comments. All good comments. I think Natan, it's BMI above 35. You pause. It's likely a contraindication for the TIF without addressing the higher BMI. And for the hill is completely what Dr. Kumbari said, is we try to keep it to 1 and 2. 3 is a borderline zone. 4 is the combination of a hiatal hernia repair with a TIF would be a better option. And the cutoff for hiatal hernia size is about 2 centimeters. So these are the answers to your question.
So the downside, so Barham and Vivek, the downside of doing one first, wait to some weight loss, and doing the other one will be the cost, will be the double risk. That will be, because if not, you will wait, you know, like sound more normal to me.
Absolutely. That's why cost, both platforms are associated with cost. So what you're trying to do is you're trying to leverage the ease of endoscopic access in order to get like 2-for-1 type of deal. And that's why we proceeded with this combination approach for this patient, is because of cost and efficiency with this procedure. Now, Dr. Gerpino, as we're going to be pulling through the GE junction, and we're going to pause at the GE junction with this cap on top of the device in forward view. Could you comment on the distribution of the fasteners as we come out?
So usually for TIF, I mean, the standard approach that we have been taught is basically to do 270 degrees, and basically we're sparing the lesser curvature. So you can see from that view, the fasteners kind of like around on the left side, and we're sparing the right side, which is kind of like the lesser curvature when you look back from the retroflex view.
So you could see here is this 2/3 circumferential type of orientation. It gives you like a rose with or a kind of a rosé kind of orientation, and that's what the valve that we try to create. Now we're gonna evaluate it in a retroflexion. And you could see we elongated the intra-abdominal esophagus by about 3 centimeters, and we create this tunnel of high pressure zone of about 3 centimeters. And here you could see that the distribution of these fasteners and the integrity of the GE junction valve with this 3 centimeter high pressure zone. Reem, Reem or Vivek, actually, both comment. Now we're going to proceed with the endoscopic anti-obesity, which is creating an endoscopic sleeve gastroplasty. I'm going to start playing the video of the endoscopic sleeve gastroplasty, but to level set with the audience, basically endoscopic sleeve gastroplasty is a transoral plication of the greater curvature using sutures. We start at the level of the incisura as shown by this diagram, and we imbricate the greater curvature in order to create a funnel-shaped stomach where there's small fundus, but there is a narrowed banana-like greater curvature, and there's an intact shorter antrum. As we start this procedure here using the Apollo overstitch, Vivek, any concerns about intubating the Apollo overstitch in the setting of the created TIF?
No, I mean, I think we do need to be mindful and careful. We don't want to catch any of the tags inadvertently as we go forward. So I would just be cautious, but not. I wouldn't be reticent to do so. Right. You do have the cable, of course, as you're running alongside the scope. So you just need to be mindful of the back and forth motions. And if you're feeling a catch, maybe be aware.
So I would like Reem to comment on technique here. Are we starting in the right place? Are we starting too distal, too proximal? And please comment on the suturing technique.
I'm not going to comment on your technique. But I will say that I echo what Vivek was sort of saying. Just be mindful of where everything is. You can lube your scope a little bit more with the with everything that goes through, but you're going anterior, middle, posterior, and depending on how wide the stomach is, I think you just have to make sure that you don't do too many sutures that are too wide apart to ensure that they don't, you have good coverage and less breakage. And as sort of the usual technique, ensure that you're using the helix, that you're getting full thickness plications, because the key thing here is durability, and you want to make sure that you're not putting either the stomach or the esophagus under high pressure zones so that anything could pop up.
All right, all good points. Here, to me, this is still the standard ESG. When we get closer to the GE junction or cardia, that's where the technique is going to differ or deviate a little bit from the standard ESG that we're used to. Before we go there, Dr. Schulman, on your way back with this U-shaped suturing, on the way back, we started on the anterior curvature, We went to the greater, so we started anterior, went to greater curvature posterior, and now we're going back. Do you do backhand suturing? That means, do you switch the orientation of the device as you go back, or you just take it in the standard orientation and create a minor loop in the plication? What's the best technique here?
Yeah, that's a great question. So I've sort of explored doing both ways. I would say that I tend to keep the same orientation and then suture back up from basically posterior to just above posterior to greater curve to just above greater curve to anterior. Sometimes, depending on the shape of the stomach, I alter that technique. And so in very J-shaped stomachs, I may actually create that loop. I haven't yet decided which is superior.
Excellent. So to a comment here, I do reinforce. I did the first U suture, and now I'm reinforcing this in order to overlap the layers, so there's no gaps in the plications.
So I'm curious, like, who does that as well? Like, I've heard some people doing that as well, where you do the one suture reinforce second versus doing a complete primary layer and then a reinforcement. How does everyone feel about that?
I do U and then reinforce immediately on the medial side, and then go up and then do the next U and then reinforce.
I do the exact same thing. I think the issue with trying to do the full U and then going back through is that the stomach is already quite tight and you're already starting to see some of the edema from the suturing. And so I feel like if I go all the way back in and do a second layer at that point, it's sort of harder to maneuver, and I could stretch out some of the sutures that I've placed. So I do a first stitch, distally, reinforce it, and then come up and do a second one and reinforce it.
Viv?
Yeah, I think when the sutures sort of cheese wire or dehiss, sort of, after a year or whatever it may be, it tends to be around this region, doesn't it? And I think that's why I wonder if you're more likely to reinforce in this area than you are, say, in the mid body of the stomach. I don't always do it. If my initial layer looks pretty good and my bites are 2 to 3 centimeters apart, I'm getting a pink out like you are with every bite here. I'm somewhat at peace. But I think conceptually, the greater the number of bites per suture and the greater the number of sutures used, I suspect, the more sort of durable your tubular-shaped stomach remains.
Mm-hmm. Excellent. Now we're going to get to the important part, which is how do we handle the cardia region? We're going to get close here, and we're getting close. Now we're going to be hitting the flap valve that we created with the TIF. To me, there is synergy in what you do here. Here, I try to follow the greater curvature of the stomach and suture that the U-shaped suture pull is pulling the flap valve and extending it with support rather than working against it. So I will bring the plication to the end of the flap valve. So now it's kind of acting in one unison here. So it's subtlety at this point, and this is such a brand new thing that we still are understanding what's the best configuration. But I would like people to comment. We're getting to the G junction. We're going to hit the flap valve here, and I still now going to put even a suture to extend all the way to the flap valve itself, which is, as you can see here, this is the squamocolumnar junction. What do people think here?
I'm not an expert on this, of course, but I will say that I will bring again the same little concern. You have now a valve to protect reflux, and even that is not a regular sleeve gastrectomy, it's a ESG, you are going to increase the pressure of the system. So that's what I was thinking, that you maybe should do this, the obesity part first, and then this one, understanding the other reason. But I will not get closer. I understand what you're saying, Barham, just the continuity of everything, but at the same time, the closer you get there, the more pressure you're gonna have. But that will be what I will thinking now.
That's an excellent point, Nathan. You're the only surgeon on the panel right now. So physiologically speaking, if you're doing a Nissen with a sleeve gastrectomy, which is a different thing completely, would you approach this similarly or differently?
You see, so my first disclosure, I will never, ever, ever do a Nissen sleeve gastrectomy. That will be my first disclosure. You see, I'm a normal person. I'm a very simple man. I like to sleep well. I sleep 2 hours a day, but I like to sleep well. So I will never do that. So because that's my biggest concern. When you do everything at the same time, you're going to have pressure in one side. You're going to have pressure in the other side. If the pressure is enough, there will be an opening. The good thing here is it's very rare that an opening happens. We're not going to get leaks or that. So, but I'm not sure how much, in our experience, the pressure of the sleeve lasts at least 1 year, 1.5 years. So I don't expect this, but I don't know, Barham, and you guys are more, you read
So
more.
maybe I can answer or
Please.
address your question that you had asked earlier. So if you just do a TIF procedure on its own, the diet post TIF will induce weight loss because they're on liquids for a while, and then it's sort of a gradual progression. So it's very similar to an ESG diet. So people on just a TIF diet will lose weight, which is great.
Rim, what about the opposite? Why you, for example, put this patient in medication or either do an ESG, but I'm same concern about the reflux, so I will go just by the medication and some diet. And then do we did it together or as you mentioned, it is, you know what I'm saying? So simultaneously, yeah.
So great question. The ESG and then a TIF would probably be technically hard because you won't have enough room for retroflexion with a TIF. So that's why both Barham and I had started with the TIF first, because then you have that option. In my particular patient, and I'm assuming it's the same with Barham, they just wanted everything done together as opposed to a staged procedure. We have definitely done staged procedures where TIF, they don't lose enough weight or they want a little bit more afterwards. But I haven't done it where you do an ESG and then you want to address their reflux, because that's going to be very technically difficult, similar to like a sleeve gastrectomy and then trying to fit the TIF device in there. There's just not much room for that.
In any of your readings, Guy, you find somebody's measuring the pressure like we did with the sleeve. Is anybody measured the pressure after the ESG? Is there much increase? Is not increase at all?
So, I mean, Barham, you can talk to that as well, but like if you think of the way we do the ESG, you're keeping the fundus open, so you're less pressure up top, and that's why, I mean, Vivek showed it with his data, less GERD in an ESG versus the surgical sleeve, right? So you're assuming it's the same thing, and you're assuming that this will treat both, and we'll show you data showing that later on.
So hold that thought. I think Reem is going to discuss that, but the short answer is, based on the state of the evidence we have right now, is we do not think endoscopic sleeve gastroplasty is a high pressure system based on physiological studies. We think actually it's a low pressure system. And that's why a combination like this is an appealing option compared to a Nissen sleeve gastrectomy combination.
I just want to make one comment back to what Barham was mentioning about the orientation, or kind of like the location of the top stitch. For this patient population, usually at our institution, I would offer like a combined procedure using application device. So like a USGI device, and then go in and then retroflex, and then use the IOP to place plications around the GE junction. And I would focus on the collapse fibers orientation. And then after that, I would do some sling fiber plications. And then I'm retroflex and then do a pose in the gastric body. And then I try not to get into the sling plication. So I kind of stop like right distal to that. So I just want to see like what you think about like location wise, where we stop the plication, would that apply to where you would stop sewing during the ESG?
Great comment. And what Dr. Gerardino is referring to is the USGI incisionless operating platform, which uses plication. And the advantage here is you have one system to do both rather than two systems. Sai, to answer your question, we did this combination in dogs. We could not figure the optimal pattern yet. So we still have a lot to learn about how to position these plications for optimal GERD outcomes. But it's a very intriguing concept because it could potentially be quite cost effective to do both in one platform, for sure. Now we're coming close to the end here, so I would like to give the last two comments to Dr. Kumbari and Dr. Schulman. So Viv, I'm going to play the video of the end product. Could you please comment on how do you like the integrity of the GE junction and on the sleeve, and any final comments that you have? And then I have a question for Dr. Schulman at the end here.
Yeah, happy to. So on this fly through, I think you can see that you've got a nice snug tubular distal esophagus. You've got a small, what appears to be a stiff, non-compliant tube, which is now the stomach. I think it looks good. No bleeding. You've taken down the entire greater curvature aspect, less the lesser curvature and antrum intact, which is what you want. Thumbs up.
Thank you. And you could see here, we paused it here, but this is the 3 centimeter tunnel of the intra-abdominal esophagus. This is all esophagus here, and it has this flat valve orientation that it's closing and opening along the lesser curvature, reinforced by the endoscopic sleeve gastroplasty. Now, Dr. Schulman, before we conclude here, a question that came through the chat, and there's a lot of good questions in the chat that will entertain them as we go along. There is data to show that some of the mechanism of action of the endoscopic sleeve gastroplasty is a delay in gastric emptying. And we know a delay in gastric emptying could worsen reflux. Is that a concern when if we're going to embark on such a combination?
Yeah, that's an excellent question. I don't think I have a great answer to that. We certainly have not seen that yet in the available data. It does, for all the reasons that Dr. Shariah had mentioned earlier, it does not appear that endoscopic sleeves worsen reflux despite the delay in gastric emptying. And a lot of it maybe has to do with that fundus still being intact, but it does not. And from Dr. Kumbari's data comparing endoscopic with surgical sleeves, we know that those patients just did not get reflux. That's certainly my experience with my large data cohort at University of Michigan as well. So I think it's going to, despite the fact that it's inducing gastric, decrease in gastric emptying, it seems like it's still not going to be increasing reflux. And so this seems like a very viable option for patients, even despite gastroparesis.
And maybe to add, if the volume of your stomach's smaller, you may be eating less. The amount of a volume there to reflux, it would also be less. So I wonder if that could also contribute. Yeah,
it's a great point.
Well, awesome discussion. Thank you, everybody. Truly, I mean, I think it's very good comments coming from experts who are doing these procedures. Now I'm going to switch the next section to my colleague, Dr. Ketan. And Lena, would you please introduce the speakers, and we could go one by one, and then we'll end that session with a discussion.
Yes, thank you, Barham. That was a super interesting case and really cutting edge. I'm really excited to hear everyone's comments about it, as the world is changing, and really the endoscopic techniques that you all have been developing have been amazing. So our next session is going to be really fun because it's really fast, and but we want to hear everyone's kind of quick takes on some of the topics in this field. So you can't beat PPIs, so stop trying. And Dr. Storm is going to be our presenter for this talk. And then the way these sessions are going to work, they're going to be about 5 minutes each. And then we'll have some time for discussion at the end. Dr. Storm's at the Mayo Clinic, along with Dr. Abudaya, and really excited to hear your take on this.
Thanks, guys, and thanks for all the attendees for being here this evening with us. It's really an honor to talk to you. So I'm a proceduralist. That's my first and foremost disclosure. And this is a surgical and proceduralist, group. But I'm going to put on my debate hat and talk about PPIs like they're the best thing that there is. So absolutely, the title, I'm going to steal a title from later where Roux-en-Y are king. Actually, PPIs are absolutely the king of GERD. You can't beat them. So please stop trying. So my disclosures briefly, just as an outline, what we'll talk about during the next 5 minutes is an introduction to PPIs and why they're king of GERD. We'll talk about why PPI failure is really a physician failure, not a medication failure. We'll talk about some randomized data behind PPI versus anti-reflux surgery, some good prospective data from New England Journal of Medicine, and then talk about deprescribing guidelines, because particularly in today's day and age, we must waste not with healthcare expenditure and environmental issues front and foremost. So PPIs are king of GERD. Absolutely true. You can't debate me on this. Omeprazole is the 7th most prescribed medication in the US. It was made new in the 1980s. It's now well established and continues to be in the top 10 prescribed medicines every year. Nearly 59 million patients prescriptions were written for PPI in 2020 alone. And at any given day, nearly 20% of the US population is taking a PPI. Compliance, which we know is a big issue in the medical world with medications, compliance typical, just so everyone's on the same page, in the US anyways, is anywhere from 30 to 50% at best for medications that we prescribe in clinic. And so compliance with PPI has been reported on average at 71%. This is the highest of any medication. Oh yeah, and by the way, it's over the counter. So this is a very safe medication such that the FDA was willing to grant it over the counter status. You don't even need a prescription to get it. Adverse reactions to PPIs are very rare to none. There's truly no definitive evidence that infection or bone mineral health, dementia, or renal function are impacted by long-term use of a PPI. So again, safety is prime. And the cost is very minimal. This used to be an argument that you might be able to make that it was prohibitively expensive, but now, I can get on Amazon earlier today and see that a 1-month supply of omeprazole is just $6 and, is shipped right to my door. So PPI failure is physician failure. I'd like to convince you of this. PPI refractory GERD is one of 5 things, and it's always one of these things. Either abnormal acid reflux despite the PPI, and maybe there we need to change the dose or change the PPI, maybe consider other medications. Reflux hypersensitivity. So this is someone who may or may not have true acid reflux, but is just very sensitive. Their esophagus is sensitive to any kind of reflux, acid or not. A non-esophageal reflux esophageal disorder. So as an internist, first and foremost, we have to think about cardiac and other primary esophageal issues, and then extraesophageal issues like cardiac, for example, as a cause of someone's recurrent chest pain and reflux symptoms. And then finally, functional disease, which is a challenge both for medical and procedural physicians. So I would say, in conclusion, PPI failure is the strongest predictor of fundoplication failure, and that's well proven across the data. If you have failed a PPI, you're most likely going to fail a procedure. More evidence of that is a prospective New England Journal paper. Patients that were highly selected from a VA population, true to their doctors, showed up for all their appointments. The 366 patients were enrolled. Only 78 were able to be randomized because it was so exclusive. But the follow-up was excellent, as you would expect in the VA population. These were patients with refractory heartburn. They had failed, in other words, they had failed twice daily PPI, maximal medical therapy. They had objectively confirmed, in other words, impedance pH probe, reflux, acid reflux. And they were randomized then to either Nissen, PPI plus baclofen, or PPI. And patients, of course, obvious to all of us, were not able to be blinded to surgery, which certainly introduces a placebo effect. So what they found is that 2/3 of the Nissen patients had at least 50% reduction in symptoms, about 1/3 with the medical therapy, PPI plus baclofen, and a little less than that with just PPI, but still in the teens. So some response to PPI, even in people who had previously been deemed PPI refractory. So what this tells me is that while most patients are guaranteed success with medical therapy, the vast majority will succeed with medical therapy. medically refractory patients are not guaranteed success with surgery. So deprescribing reduces waste. You've all probably seen this, but in April of 2022, the American Gastroenterological Association released some really great guidelines that I send to all of my primary care colleagues who are asking for help in de-escalating medications and shortening patients' MARS. So the PCP should certainly be regularly reviewing the indication for PPI. In general, we can counsel people that other physicians that almost never should a patient be on a twice daily PPI for more than a short period of time and for very specific indications. Many patients take the medication incorrectly. So PPIs poison proton pumps in the stomach wall. They do so for the life of a proton pump, which is about 7 days. And they're only able to be poisoned when they're turned on. That only happens when you eat a meal. So that's why we recognize that patients need to take this medicine 15 to 30 minutes, ideally before a meal, and every 12 hours to keep it in your bloodstream. The half-life of most PPIs is about 16 hours. That's why the twice a day is considered maximal, but often unnecessary. And then tapering or abrupt discontinuation is actually fine. This is, they give some guidance that if you're going to stop a PPI, you may counsel patients, no matter how they do it. They may have some heartburn that tips up because they're discontinuing the PPI, but that should get better with a little bit of time. So PPIs certainly are overprescribed and not well deprescribed, and that's probably what leads to some of the negative press about PPIs. We're definitely using too much of them. So I will highlight then as my final point that PPI's 90-day mortality is 0. So medications love you, you should love them. Looking at almost 9,000 fundoplication surgeries in Sweden over a 10-year period, let's just suffice it to say it's not 0. So in conclusion, PPIs are king of GERD. PPI failure is often physician failure. A failed PPI will fail a Nissen often, and deprescribing PPIs reduces waste. Finally, maybe the biggest point, PPIs don't kill. So I'll summarize my argument that you should think first, which is to say use a PPI and then cut last.
Thank you so much, Andy. That was great. Now let's hear Dr. Ujicki, who is the chief of GI and general surgery at North Shore Hospital. And he's going to share with us, you know what, PPIs don't actually fix the underlying problem.
Thank you. I want to first start by thanking you for the opportunity to clarify some things that we just heard. It reminds me a little bit of the, if you look back 50, 60, 70 years, you might see a lot of false advertising. And, I think we heard a bit of that just now. So, hopefully I'm glad that I get the second or the opportunity to speak last with no opportunity for any rebuttal by Dr. Storm. But in all seriousness, I do a tremendous amount of anti-reflux surgery, and I use PPIs all the time. And so, though I disagree with some of what was just said, I do think PPIs are an excellent medication, and I do prescribe them. But I do want to point out a few things. And, this is something that we learned at our first AFS meeting back in 2019 from one of our past presidents, Dr. Peter Karillis, who many know is one of the probably the foreign expert in reflux, that if you look at Newton's law of motion applied to reflux, which we've been able to prove over the years is really the right way to look at it, there's really nothing about, over acid production or anything in this equation. It's really about pressure differences between the abdomen and chest, and most importantly, the diameter of the EGJ opening, which is to the 4th power. So if you can affect that, and we heard a little bit about that in the case presentation about Hill grades 1, 2, 3s, and 4s. Clearly the diameter of the EGJ makes the biggest difference. And that's what we can fix with surgery. PPIs don't fix that. PPIs just decrease acid production, They don't do anything to the anatomy of the valve. And this is an anatomical problem. I probably saw 15 patients today where I had the same conversation. Why is my PPI not working? Why is it not helping me? I've been on it for 15 to 20 years. My GI doctor tells me I have 100 polyps in my stomach. I'm anemic, and my symptoms are still bad. And I tell them, because this is a mechanical problem. This is not an acid overproduction problem. And one randomized controlled trial was pointed out to you just before this out of the VA with kind of a small number of patients. But let me point out a couple other randomized trials that were done. One of them was, and the more important is not the comparison between what procedure was done, although I will point out that Nissens are being done much less commonly now than before. And whenever I see now randomized trials looking at Nissens, I'm not really sure that those matter anymore, because there have been enough randomized trials with enough long-term data to show that Toupees are superior to Nissens, that I'm not sure any comparison to a Nissen right now is even valid. But in this case, we were looking at magnetic sphincter augmentation, or LINX, versus double dose proton pump inhibitors. And if you start on the right side, you can see here that there was some normalization, some improvement in pH in the PPI group. But of course, the LINX group was superior. And then as you move to the middle, if you look at what the symptoms reported, moderate to severe regurgitation was almost unchanged in the PPI group, whereas in the LINX group, we saw 80% with no regurgitation at all. And if you look at the mild regurgitations plus no regurgitation, you were you were over 90%, basically regurgitation for the most part controlled. And then if you look at the very left here, you have relief from regurgitation, 90% in the LINX group versus 10% in the BID PPI group, and improvement in GERD HRQL scores, very similar results, as well as satisfaction. Look at how few people were satisfied with their condition on PPIs versus those with LINX. And then we heard a little bit about TIF. Here's the TEMPO trial. And so let's look at the results here. Again, the TIF is affecting what the problem is. It's improving the lower esophageal sphincter, which, as we saw in the equation, needs to be done here in order to really prevent any refluxate from coming up from the stomach. And so, as you can see here, if you look at, it starting at the bottom, if you look at PPIs on max daily dose, and you see the healed and reduced esophagitis, the TIF was superior. If you look at elimination of heartburn, again, TIF is superior. And then if you look at specific symptoms like hoarseness, clearing, the top graph, hoarseness, clearing of throat, excess throat mucus, dysphagia, in all of these, we see that if you actually fix the problem, which is either an open lower esophageal sphincter or one that is inappropriately opening at inappropriate times, anytime you affect the valve with a mechanical fix, you're going to fix what is a mechanical problem. And then if we talk about obesity, which we're really here to talk more about obesity today and reflux, this is an even bigger problem, because as we know from John Pandolfino, if you look at intragastric pressure and look at people with different weights, well, obese patients have a higher pressure. And so what does that higher intragastric or intra-abdominal pressure from being overweight cause? Well, if we go back to our original equation here, you can see that the pressure difference between the abdomen and chest is directly related with reflux volume. So as that abdominal pressure goes up, reflux volume will go up. So again, if you have an obese patient, and in that first case, if PPIs had worked, if she hadn't had an allergy or side effects to the PPI, that's a patient who's probably still going to have a significant amount of reflux volume, and heartburn may be treated, but regurgitation is not likely to get better, as we can see. So I really think, we're limited to 5 minutes. I have so much more to say about this. I wish I could, but I think it's quite evident that, PPIs are not actually treating the problem. It's just decreasing acid. The real problem is a mechanical one. The lower esophageal sphincter is hypotensive or it's relaxing inappropriately, and we need to fix that. Oftentimes a hiatal hernia is the cause, and a hiatal hernia would need to be fixed. We have plenty of data to show using EndoFlip that the crural closure is probably even more important than tightening the lower esophageal sphincter, which I think is why you're seeing this experimentation with C-TIF, because we know that a TIF without crural closure is bound to fail. And so again, I'm happy to take any questions later, but there's no question if you just look, and by the way, Peter Karillis, as you all know, is a GI doctor. So, this is the GI doctor right here telling you that this is a mechanical problem, not an acid problem. So thank you very much. And I'm glad I got to speak after Dr. Storm.
Thank you, Mike. That was great. Spoken like a true surgeon, so that was wonderful. Now, so actually, we're going to hear one more perspective. Okay, we talked about surgery, we talked about medications. Now we have Reem Shariah from Cornell, an expert in endobariatrics, endoscopic approaches to GERD. And she's going to tell us about how endoscopy will offer cost-effective GERD and obesity solutions. So Reem, take it away.
Okay, I'm just wasting time because there's not much data to talk about here, except to say that endoscopy will offer cost-effective GERD and obesity solution. So here's what we do know. We know that obesity is a global health epidemic, and there is a considerable economic burden on the world with the treatment of obesity. And GERD is highly prevalent in patients with obesity. We've seen the data for this and we've discussed this. And many attribute the increasing BMI to the increase in GERD prevalence, and both Barham and Mike and Andy all talked about the mechanism for that. So we know that the rates of GERD has been going up, and the rate of obesity has also been going up. So the mechanism of reflux in obesity, we talked about that, so I'm not going to belabor the point, but essentially it's the high intra-abdominal pressure. Think pregnancy, you get delayed esophageal transit time, increase in the lower esophageal sphincter relaxation, you have overeating, you have increase in intra-abdominal pressure. The mechanism for GERD is, as we mentioned several times, it's physical. So you have the sling clasp deficiency, the uncoupling, a lot of things that are happening. And I won't go into that. So what we do not know is what's the optimal treatment for GERD and obesity. And we talked about that in the case scenario that we just described, whether it's PPI, surgery, or endoscopy. We do know that you get GERD after bariatric surgery, but there's a lot of debate as to the mechanism behind that. I've heard Dr. Ketan said, well, people who get it don't do the sleeve appropriately or properly, and there are different ways you do it where you can minimize the rate of GERD post-surgery. Should everyone get surgery? What type of surgery? We're going to hear about 2 different types later. And what is the true rate of de novo GERD? What about endoscopy? So there was a lot of questions from Natan on, does it truly lower the rate of GERD? What do we know about it? And does improving GERD improve does your GERD improve if your weight improves? So surgery, we're not going to talk about it. Barham mentioned this. Nissen fundoplication in patients with obesity have a high failure rate. Sleeve, we'll find out in the next lecture. And Roux-en-Y gastric bypass, is it really king? I do want to point out that no one mentioned the queen, so I'm taking it as endoscopy is the queen of treatment. So endoscopy can be a standalone procedure. You can do both ESG, pose, or balloon, depending on the treatment choice for each patient. And you can do them alone, and you'll see an improvement in reflux in those patients. But you can also do them together. You obviously can't do a balloon and that, but you can do an ESG and TIF and a pose and TIF. Balloon and TIF is contraindicated. TIF after a balloon post-TIF is also contraindicated because of the rate of disruption. And then this is the question that Natan asked, do we do just a TIF? But potentially in patients with obesity, if we're thinking it's the same with Nissen fundoplication, then you might have a higher failure rate. So this is a study from Vivek Kumbari when he was at Hopkins, comparing endoscopic sleeve versus lap sleeve. The weight loss obviously is better with the surgical component, but what he did show, and he was one of the first studies showing that you get lower rates of GERD with the endoscopic approach. And we do know from data from the MERIT study is that you have significant improvement in GERD at the 12-month mark when patients got asked GERD questionnaires monthly compared to lifestyle alone. So endoscopy is cost effective. It's a day procedure. You have less length of stay. Patients really leave the same day or within 24 hours, depending on the institution. You have less adverse event rate, probably not zero like the PPIs, but you have less OR time. This is a cost-effective analysis we did without obesity, but it basically shows that ESG is cost-effective in patients with obesity below a BMI of 40, comparing lifestyle, intragastric balloon, and sleeve gastrectomy. And you can argue that if you add in GERD to this, you might get the same results, although data for that is lacking. So data that's fairly new, obviously I mentioned the MERIT trial, and hopefully we'll see publication soon, but it's the randomized controlled trial of ESG versus lifestyle. And as I mentioned, there was significant improvement on monthly GERD questionnaires for up to 12 months compared to the RCT group. The compo ESG TIF, as Barham showed, we've also published on this, but we want to think of it, you're getting two devices, you're costing two devices, but is it still cheaper than surgery? I think we just need to put in the numbers, but it probably will show that it is. So both we have case reports from Cornell and Mayo. For us, I know at Cornell, we've definitely shown normalization of GERD on Bravo post at least up to a year, and significant improvement in weight loss, and publication is pending for those for the actual like case series. So in summary, endoscopy is probably the way to go, and it's definitely cost effective if you think of the cost, the length of stay, and adverse events. Thank you.
Thank you so much, Reem. So, so endoscopy now is a player, and so this is pretty exciting, and we're going to have a few minutes to discuss this shortly. Now we're going to bring up a video. Unfortunately, Dr. Texera was not able to join us, and he's a surgeon at the Orlando Weight Loss and Bariatric Institute, and he's going to talk to us. Sorry, I gotta have my notes here. He's going to talk to us, is sleeve gastrectomy out when it comes to GERD and obesity?
We don't have a audio. Probably need to put in the under the screen share activate audio thing.
Should we go with see if Dr. Wilson's ready?
Yeah, Eric, are you ready?
Maybe while she's figuring
Yeah,
out the
I'm ready.
technical difficulties. Thanks, Eric.
I'm
Yeah, while
ready.
she's working on the technical stuff, I'd like to introduce Dr. Eric Wilson, who was kind enough to join us this evening, and he's the director of bariatric surgery at Memoriam Health, and is a professor of surgery at the Texas Medical Center in UT Houston. And he's going to talk to us about why gastric bypass is king.
Yeah, and after I talk, you probably don't need Andre to talk at all. So, but can y'all see my slides?
Yeah.
All right, cool. All right, thank you. It's an honor to be here. I appreciate it, and I love getting the title that gastric bypass is king. So, as a disclosure, I've got lots of conflicts of interest, but as a disclosure specifically to this, I would say that these are both chronic diseases, obesity and GERD, and you just can't argue one operation is going to fix everything. And but that's what I'm about to do, because I'm going to talk about bypass. So That being said, it's really hard to, if you have both reflux and morbid obesity, it's just really hard to argue against doing a gastric bypass. I'm not saying it's the only thing you can do, but for anyone saying, oh, it's a terrible idea, I would certainly disagree with that. So, I think there's been great talks talking about the components of reflux. We know it's a complicated problem. We know it's a mechanical problem, not just a problem of acid. It's about the sphincter and what occurs above and below it. And we obviously know that there's a whole bunch of weight loss operations, some that contribute to more reflux and some can contribute to less. We know about the downturn of gastric bypass and the growth of lap band that then, retracted. And one of the problems with lap band supposedly was its reflux problem. And now sleeves all in. And now we're talking about, sleeves potentially having a lot of reflux issues. If you look at the market history of bariatric surgery, the bright yellow right here, that's bypass as far as percentage of cases. And over the entire course of bariatric surgery, it always seems to come back. So I think if you say what's going to be around, I'm not saying any of these other operations necessarily going to disappear, and I'm not trying to hate on sleeve, although a little bit just for fun. But I do think that a bypass is a very valued option in many situations, especially when you're dealing with reflux. And there's 3 big issues with sleeves. There's 2 big issues with bypass that on the long term, it's marginal ulcers and internal hernias. Sleeves have 3. They have chronic leak problems, reflux, and weight regain. And this is a paper that just got published that showed at 10 years follow-up, when we compared the evil lap band at 10 years had almost the same long-term weight loss as a sleeve gastrectomy. I think that's real telling about our environment around bariatric surgery and how we talk about what the latest and greatest thing and how it's just so good. And then we look at the long-term follow-up and we start to understand the chronicity of the disease. And of course, there is a risk of Barrett's. This is the original Ginkgo article that had a 17% Barrett's rate. There's another meta-analysis that just came out at 3 years showing 11.8% Barrett's. And Barrett's is not just a disease of acid, but also of bile, and intracellular bilirubin has been measured by pathologists. This is an old Demeester article, and his pathologist showing bilirubin in the Barrett cells. So, when you add sleeve to it, it's even more complex because you've added additional factors that contribute to this: angle of His, incisura, pylorus, tube attached to a tube. These are all additional factors for reflux. So if you look at patients with really end-stage esophageal motility issues, this has been studied. This is all extremely old data, 15, 20 years. And look at how people do when they do a bypass, they just do better. If you compare them versus esophagectomy versus Nissen, and they have complete esophageal failure, they do better with a bypass. Well, why is that? So it really comes down to, we all know about the problems with the valve, but you also have to have a volume to refluxate. And if you don't have a reservoir of refluxate because you have a really small pouch that drains really, really well, it's really hard to have reflux. And that's why a bypass does such an amazing job with managing reflux. This is an old study from Aldo Frieza, 2002, 20 years old, showing how good people did after Roux-en-Y when we first started really studying it. This is another really old study published in 1984 that randomized Roux-en-Y duodenal diversion versus fundoplication, and it showed that they did much better with a diversion, with a biliary diversion, with a Roux-en-Y than they did in Nissen when you followed them at 5 years. This is another old study that looked at long-term patients with obesity and doing fundoplication, and as everyone knows, you have higher reoperative rates, higher recurrences after Nissen fundoplication over time because of the disease of obesity. And this shows that if you have intractable reflux and they failed a standard reflux surgery, one of the big options to consider is converting them to a Roux-en-Y, and that it works really, really well. Again, an old paper. So this is not new. So it's actually quite frustrating when you have a patient that has really bad reflux and you can't get a Roux-en-Y done on them because the insurance company is telling you that that's a bariatric operation only. So if the patient has a bypass and they have reflux, there's something going on, and that does happen. So I'm not saying that there are no bypass patients that don't have reflux. In fact, I just saw a patient who had a gastric bypass by some other surgeon 15 years ago and has a Demeester score of 71. So she has definitive objective reflux, but something's going on with her. Well, you work her up. She's got a very large gastric pouch. That's her reservoir. And she's got a pretty significant hiatal hernia associated with it. And I am going to go re-repair a hiatal hernia, but all I'm going to do is I'm going to make her pouch a lot smaller. I'm going to make sure she has no intestinal partial blockages distally and address that. And I am quite confident that her reflux is going to be dramatically improved. So you do have to look at what's going on when they have a bypass. But, you know, just to summarize, since we're only talking for 5 minutes, you know, obesity and GERD are complex and interrelated, and we should be adept at managing them both very well. I think the future of reflux surgery involves bariatric surgery and vice versa. And we need to support the surgeries that support the valve, but also reduce refluxate in patients with obesity, recurrent reflux, progressive Barrett's, and severe reflux with aspiration. And a well-constructed small bowel pouch gastric bypass, an important operation for bariatric and foregut surgeons. With that, I will finish up.
Thanks so much, Eric. That was great. And yeah, bypass is king in a lot of ways. And you'll hear in my talk a couple of these things echoed. So thanks for sharing. Skylar, are we able to bring up Dr. Texera's presentation now?
I thank you for the opportunity to participate on this conference. My topic today is sleeve gastrectomy out when it comes to GERD and obesity. So, how do you say no in Portuguese, right? I don't think it's out. Sleeve is still part of the armamentarium, even if you have reflux or not. The data, right? We have systemic review, prospective data, retrospective data, case reports, sleeve pus, impact on the sleeve in reflux. We have so many different data that we can talk about nowadays about reflux and GERD. Some of the data is kind of confusing. So how we do it? I mean, how you come up with a way that you can exclude or not sleeve gastrectomies? Well, we need to figure out what's the causes for GERD, right? In our institute, for example, obesity, weight regain, transient lower esophageal relaxation, incompetent lower esophageal sphincter, esophageal factors, hiatal hernias, obesity and GERD, right? So we need to work up. The best way to work up those patients, right, is an upper GI, an endoflip with an EGD, Bravo pH studies, manometries, just to start your workup, to be able to exclude or include sleeves for patients who have reflux or not. Mechanical issues, sleeve twists, strictures, hourglass sleeves, retained fundus. Those are all mechanical issues that can cause a reflux. So all technical mistakes that is leading to a reflux. Technical issues are very less forgiving on a sleeve versus a gastric bypass. You pre-op workup, EGD, upper GI, manometry, pH manometry, endoflip, like we talked about. We need to have some kind of scoring method to be able to see if we can predict if a patient will develop reflux or not with a GERD, because they do have GERD prior to it. It does not mean they will have afterwards. The endoflip is a simultaneously measure the area across the inside of a gastrointestinal organ and the pressure inside the organ. The ratio of the two measurements is called distendability, and that's what we need to look at, distendability from the lower esophageal sphincter. When you look at the use of impedancy of an endoflip in a foregut surgery practice experiencing more than 400 cases, so the objective was assessment of any sphincter of the GI tract, right? Is it useful in many clinical settings and scenarios as we talk? Pneumopathologies, we can use this: Zenker diverticulum, gastroparesis, achalasia, hiatal hernia repairs, reflux. So it is a tool that can give us more data than what we need to be able to determine if we can come up with a patient that will develop reflux or not. Predictive factor of reflux after bariatric surgery, controlled trial comparing sleeve and gastric bypass. It's an interesting study done, the pre and post. When you look at the pre-GERD 1 year follow-up, 14 of the patients typically had GERD symptoms on the sleeve gastrectomy. And when you look at your baseline, okay, it was 13, so it didn't change much. When you look at your baseline, hiatal hernia is 11 of them. And then when you X-ray post-op 1 year, 21 of them had hernias, which could be causing some reflux because of the pressure. But interesting, in your baseline, there were the mystery score of 10, right? And then 1 year follow-up, 34 compared to bypass. So yeah, I mean, if you look at that patients just symptomatic, you can have more reflux on patients that do not have reflux de novo. Then we have the sleeve plus, right? Which is the sleeve plus something else like a hiatal hernia repair, links, door, anterior door fundoplication, a sleeve alone, but just by weight reduction itself can increase your heartburn. Sleeve plus ligament teres, TIF, strata, which is our endoscopic techniques that can help us with the sleeve of patients that have reflux. When you look at the definition of one of the best procedures in terms of how to do the best sleeve, will be basically you need to have a little bit of a larger diameter close to the antrum, and then a little smaller diameter as you move up to the angle of Hayes. You have to keep the acute angle and you preserve the sling fibers. You should have no narrowing whatsoever at the tube. What we tend to see a lot is some degree of narrowing in the incisura. And that can cause the hourglass appearance and the severe reflux and some twisting. What do we need? We need better predictors for GERD after sleeve, a score pattern to detect high risk for GERD after sleeve, better control surveillance after sleeve, so we can really actually understand the causes of the sleeve. Should we keep sleeve patients on long-term PPIs? Also, another thing that we see on the data is most of the patients that have required revisions of a sleeve to gastric bypass was patients that had weight regain. And those are big proponent to increase your reflux after sleeves. Thank you very much. This is my email and my cell number.
All right, fantastic rapid fire lectures. Gave us different point of views and different options. And through these rapid fires, we heard a lot about kings, and now we'll give the queen the final say. So with that, it's my honor to introduce my co-chair of the bariatric committee, Dr. Lina Kaitan from University Hospital in Cleveland. She's the head of bariatric surgery and an experienced endoscopist and an experienced surgeon as well. And I'm sure she's going to give us a balanced view about future paradigms in managing these two comorbidities. Lina, the floor is yours.
Thank you, Barham. Let me bring up my screen. So we have had some fantastic talks this evening, and you know, a lot of the people said a lot of the things that I was going to say, and I know we're also getting short on time. So I may gloss over a couple of my slides so that I can share with you the ones that I think bring something new that we haven't talked about yet this evening. You know, these are my disclosures, and we'll talk about obesity. We've already heard a lot about its effects on GERD throughout the evening. Choice of anti-reflux procedure. We've heard a lot of opinions. I'll give you my take on it. The weight loss surgery effects on GERD. Again, we've heard a little bit about that. And then management of GERD after weight loss surgery. So I'll finish out. I definitely know I am not the queen, but I'll be happy to share with you my perspectives as I'm able. I mean, we already know GERD and obesity are problems, and they're equally increasing over the years. We also know, we've heard from Dr. Ujicki that reflux happens, and Reem touched on this. Many of our speakers touched on this. There are patient factors, there's physiologic factors. The LES is important. Hiatal hernias are important. Transient LES relaxations are important, and I'm educating my residents and fellows about what gastric yield pressure means all of the time. And then, of course, once our patients have had gastric surgery of any kind, the altered anatomy can also participate in the reflux that happens, as alluded to by Dr. Wilson, where he said that the bypass is the king, but the volume of the refluxate is important. We also know that in obesity, there's a lot of unique factors that can contribute to patients' reflux. In addition to some of the things that have been mentioned, the intra-abdominal pressure has been physiologically studied. I'll share this with you. Patients can have poor food choices that can really affect their physiology. So we really have to take all of this into effect or into consideration when we're treating this disease. I mean, for every 5-point increase in BMI, and this is a great read if you ever want to do some light reading, the Demeester score goes up by 3. I think that's fantastic info. More BMI is associated with higher LES pressure and higher contraction amplitudes. Now, I would say there's a lot of data since this time that argues in different directions with this, but this was one of the things that was pointed out in this study. BMI is independently associated with the severity of GERD. And I think that this is where we kind of hit the nail on the head, being able to predict who's going to get reflux after weight loss surgery. You know, who has reflux that is independent of their obesity, that really has to do with those other physiologic factors I pointed out on the earlier slide. And most morbidly obese patients, a lot of them will have reflux despite normal LES and motility, and that plays into the point before. But we definitely need to take all these into consideration when addressing obesity. Their girth also is associated with their reflux symptoms. We also heard about Barrett's earlier today. So we know that obesity is an independent risk factor for Barrett's. So in my practice in general, if a patient has a BMI under 35, I'm gonna be okay with traditional anti-reflux procedures. But if their BMI is over 35, I'm really gonna steer them toward weight loss surgery. Most of the time bypass. There's data, as pointed out previously, that anti-reflux procedures do not work well in obese patients. And this is just a few of the studies that are out there. And I really think that it's important to realize that, you know, if an obese, you know, through my career of over 20 years now, there's been a real transition in the management of reflux in the obese. In the early 2000s, we had all of these great studies saying, you know, it's okay, it doesn't matter what their BMI is, you can do a weight loss surgery, or you can do an anti-reflux procedure. But I'd say in the year 2022, kind of most surgeons would err toward the side of an anti-obesity procedure to treat the reflux. And as Dr. Wilson pointed out, our biggest hindrance to actually doing bypasses for many of these patients is their insurance coverage for bariatric surgery, as the bypass is not recognized by insurance companies as an anti-reflux procedure. So treating reflux has changed a lot over the years, and the recognition of the obesity contribution has been a big part of it. Now, the endoscopic procedures, we've heard a lot about these, RF ablation, transoral fundoplication, arms, and as we go through the rest of the talk, hopefully I'll share with you where I think these fit in. So now let's shift to weight loss surgery and how that affects GERD, because if we're talking about the obese patient, you know, we want to, I've talked about how I want to do a weight loss operation. And does GERD affect my choice of weight loss operation? Absolutely. And in every patient, I do a GERD quality of life. I find out about their dependence on PPIs. If the patient says to me, you know, I cannot miss my medications at all. For me, that raises a red flag, of course. And then we also talk about dependence on food, their lifestyle, the severity of their symptoms. And then I do a standard preoperative endoscopy on every patient prior to bariatric surgery. Although that's not routine in all practices, the ASMBS has recently come out with guidelines recommending or outlining that it may be a considered paradigm for all of us to do preoperative endoscopy. When I have those patients who want a sleeve but tell me they can never miss their PPIs, I use high resolution manometry to help me. And perhaps if I was Mikey Jicky, I might use the EndoFlip, but currently this is how I use it. I ask them, you know, okay, you really want a sleeve. You definitely don't want to bypass, but your reflux is unrelenting. I'll get the high resolution manometry if their LES pressure is under 15. I think that the gastric yield pressure is always going to be pushing that sphincter open, and I avoid a sleeve. If I get that study, I get that evidence, and the patient says, well, the sleeve is the only procedure I want, I will not do a bypass, then for me, I actually will not proceed with a sleeve. And to this day, I've only had one patient who decided to go to another program and get their sleeve, but then came back to me a few years later to get converted to a bypass for their unrelenting reflux. So this paradigm usually has served me well. So I get the quality of life in all patients. If they have pathologic GERD or regurgitation, I avoid the sleeve. I assess that dependence on the PPI. As long as they can miss their meds for a couple of days, it's good. If the patient's a very high risk patient, so if the patient has an LVAD in place, but they do have terrible reflux, I'm going to tell them that, you know what, you might still have reflux or it might get worse, but we're going to stick with the sleeve. So I do take their ASA class and their comorbidities into account because the sleeve is just faster and less anesthesia time means fewer complications for some of these super high risk patients. And I do a preoperative EGD in all patients so that if they do have Barrett's, I avoid sleeves. Although over the last decade, I would say we've learned that all Barrett's is not the same. So a couple islands, a couple tongues of Barrett's here and there is way different than circumferential, is different than short segment versus long segment. So I think that there's still a lot for us to learn from that paradigm. And then as Andre pointed out, really important for us to make good sleeves. And that allows me to transition to the next thing that I was going to talk about is, okay, there's a lot of data out there that sleeves and bypasses improve reflux, improves weight loss. We don't have all that abdominal pressure pushing up on the LES and contributing to Newton's laws. The patients get accelerated gastric emptying, so they don't have that refluxate volume to go up. And because they have fewer parietal cells, there's decreased acid production. Yay, so that used to be the thinking, that all these procedures will improve reflux. And as Dr. Wilson pointed out, the smaller pouch leads to fewer acid-producing cells. There's less contents to actually regurge. Bile reflux is eliminated in this procedure. Somebody had mentioned that in the comments. What about bile reflux? I mean, if your bypass has an appropriate roux limb and there's no distal obstruction, bile reflux shouldn't even be a thing for those patients. The weight loss will decrease the abdominal pressure and reduce the effects of obesity on the reflux. When we look at a sleeve for reflux, it's kind of more controversial, right? We've talked about, you know, in many patients, we found that it actually worsens GERD, and then there's a lot of arguments that it relieves GERD, and we've heard many of those this evening. Most recently, the ASMBS also attributed reflux to sleeves quite a bit and said that if a patient has reflux esophagitis, we shouldn't do a sleeve. But you're only going to know if they have reflux esophagitis if you do a preoperative endoscopy. And we also know that the symptoms don't necessarily correlate with your endoscopic findings. So my only plug would be there for doing a routine preoperative endoscopy. There's a ton of articles out there saying that sleeves worsen reflux. There's also this wonderful article that Aurora Pryor and her group wrote. And in one table, they talked about the mechanisms leading to gastroesophageal reflux disease after the sleeve. And if you look at these, a lot of them have to do with the morphology of the sleeve, and only a couple of them have to do with the patient's own physiology. And then she also reviewed all the studies that looked at proposed mechanisms to minimize reflux after the sleeve. And again, a lot of those had to do with sleeve morphology and less with the LES and hiatal hernias and those sorts of things. So I think that there's a lot of different perspectives on this and a lot for us to think about. But I kind of took this concept of the sleeve morphology and tried to run with it in our own practice. Many of us have seen the sleeves with the fold. Many of us have seen this retained fundus causing sleeves, a stricture or a narrowing at the incisura leading to reflux. These are common things. Many years ago, I looked at the endoflip and used it actually in the sleeve using the longer balloon and looked at the different shapes of the sleeve. And then we followed this up with a study looking at, we do routine esophagograms after all of our patients after the weight loss surgeries. And we looked at, does the sleeve shape make a difference, and are we making different shaped sleeves despite using similar techniques? And in fact, we found that we did, but we found that those with the lower pouch anatomy, also can call it a hockey stick or a stocking, has less GERD, and that's been corroborated in other studies. So then I looked at my patients who were greater than 8 years, and my fellow Dr. Alvarez just presented this at SAGES, and I'll share with you some of our data. We looked at all of our patients who had primary sleeve gastrectomy, and we looked at the sleeve morphology classified by the radiologist and the surgeon, and looked to see if that correlated with GERD and weight loss. We had great inter-rater reliability. Obviously, the majority of our patients were female. We saw a great improvement in their comorbidities and resolution of many of these diseases, and reasonable weight loss. Now, if we looked at the different shapes, that being dumbbell, lower pouch, tubular, and upper pouch, and this is between two surgeons at our institution who were there a long time ago, we saw that there was really no straight morphology that was favored, which is interesting, because do we make the sleeves this way, or do they become this way, right, over time? But the most interesting thing about this is that if we looked at their GERD, okay, preoperatively, we actually saw of the patients who we had follow-up on greater than 8 years, more had postoperative GERD. Now, a lot of our patients we didn't have greater than 8 year follow-up on, so there may be some bias here. But we didn't see that this increase in GERD had anything to do with their morphology, the surgeon, their preoperative BMI, or whether a hiatal hernia was performed at the index operation. What we did find is that postoperative GERD was linked to superior weight loss, which I think is kind of interesting observation, something for us to take and chew on, and more common in women. And then when we looked at the morphology, we noted that those with the dumbbell morphology had inferior weight loss, whereas those with the hockey stick kind of lower pouch morphology had the superior weight loss. So these are a lot of things for us to take into account. So if somebody comes to me with reflux after a weight loss surgery, I'm going to work them up just like any other patient who comes to me with reflux, keeping in mind that our treatment options are going to be different for these patients because we don't have a fundus, even in a bypass. Me personally, I don't think that fundus and the remnant can be used for that plication. If you look at the Nissen as originally described, the whole concept was that that fundus would distend with eating, and squeeze the LES shut. So if you use the excluded fundus, it's not really going to distend. So how's it going to squeeze that LES shut to provide an anti-reflux barrier? But that's just my personal opinion. Look forward to anyone's comments on that. Esophagram, reflux studies, manometric findings. Really the manometry to me has been one of the most helpful. I think esophageal physiology really helps us a lot in understanding how to manage the reflux. And because as a surgeon, I can't change how the esophagus works, right? I can find distal obstructions, I can do something. The LES is one of the few things that I can actually do something about. And so I think it's an important component of the GERD, as Dr. Ujicki shared with us. We got to take care of the underlying problem. It can be loose, it can have transient LES relaxations, and really the manometry is the key to understanding its function. And we now know that although Dr. Wilson shared with us that the bypass is king, the LES still is a thing. So there is actually reflux after the bypass. So I've actually put some links on some bypasses and had great outcomes. This is just sharing with you some manometric findings as a patient after sleeve. You can see that they have a very hypotensive LES. They have a hiatal hernia and kind of a high pressure between the LES and the hiatus. A lot of these patients tell me they have a cough or they'll present with cough. I also think that the manometry can be used as a surrogate for pressure within the sleeve. I mean, you can use an endoflip and transduce it and find out the pressure in your sleeve. But also on manometry, if I see a lot of this high pressure distal to the LES, then those patients I'm going to be more inclined to convert to a bypass. So this is kind of my algorithm. If somebody has reflux or regurgitation or can't stop their PPI after the surgery, I'm going to work up their reflux. If they have a hiatal hernia, I'll fix it. If they have a morphologic issue, I'm going to convert them from a sleeve to a bypass. And if they have an LES problem, then I have the option of augmenting it. And I've used RF ablation as well. I think that that can be very helpful in these patients. And I'll share with you how I choose those patients. EndoStim is out there. I haven't used it and it's currently not on the market, but maybe a technology for us to leverage in the future. ARMS is another anti-reflux procedure that we may be able to leverage in these patients in the future. In the interest of time, I'm just going to skip my video here and just share my algorithm. So I shared with you that if a patient has persistent reflux after a sleeve, and I'll just focus on the sleeve here for a moment, I'll convert them to a bypass if they have abnormal morphology, their BMI still over 35, or they have high pressure within the sleeve, as I showed you on the high resolution manometry. But if they have normal sleeve morphology, I think this kind of opens up what we can do. If they have regurgitation, pathologic reflux, their LES pressure is reasonable, then these are the patients I'll use the RF ablation in. Okay, but if the LES pressure is low, then I will use magnetic sphincter augmentation as long as their DCI is reasonable. So when I applied this to my patients, I put 53 patients through this algorithm. Only 31 actually had to be converted to a bypass. Many had a concomitant hiatal hernia repair, as that's a very important aspect of the reflux mechanism. I did an RF ablation in 2 patients, and 13 patients had LES augmentation. And with that, their GERD qual scores were significantly improved, and their PPI use essentially was completely resolved. So I think if we're looking at how to manage reflux in these patients, we really need to figure out, separate, how much of that reflux is the physiology, like the LES, the motility, and how much of it is the obesity. And if we could figure that out pre-op, and Dr. Teixeira actually pointed that out in his talk, then maybe we can better decrease our reflux after procedures. Maybe we should be doing more preoperative physiologic studies, but I mean, to get bariatric surgery in the United States is an onerous process. If we ask the patients to do an additional motility and pH study, I think they would lose their minds. And but once we do determine reflux, we have lots of tools in our toolbox that we can use based upon the physiologic workup, and endoscopic approaches definitely fall into the paradigm. So thank you very much. And we have 3 minutes for a discussion.
Awesome. Very excellent talk, Lena. Thank you for putting it all together. Just a couple of announcements is the entire webinar will be at the recorded and is recorded and will be posted on the AFS website. And we're hoping that each of the bariatric committee webinars will follow with a clinical algorithm that will be published in order to guide or help with clinical decision making and workup for the community of AFS. With that, I think I would like to seize the few more minutes that we have and ask 1 or 2 important questions. There's been a lot of emphasis on ROA gastric bypass for management of both obesity and GERD, appropriately so. There has been a kind of diminished emphasis that I scope a lot of gastric bypass patients, and almost all of them have a significant hiatal hernia and an abnormal anti-reflux barrier. And we neglect that we are destroying most of the ligaments with the gastric bypass. We're decreasing the accommodation of the proximal pouch, and patients will lose weight. That means that they will lose the fat pad that is wedged in the hiatus, and ultimately a lot of that complex is going to herniate above the diaphragm, and we've seen it a lot. If it's a hand-waving estimate, I would say 80% of patients I scope, if you look, will have a hiatal hernia. I see a lot of head shakes disagreeing with that number. That's why I said it's a hand waving thing, but I would like people to comment on that.
Barham, this is Eric. I'll obviously comment on it. And you and I've had this discussion before. Look, if you look at patients as they lose weight and they have lots of fat in that area, they certainly can get some loosening, and you can see that. The question is how clinically relevant that is. And, you know, when patients even complain of subjective reflux and they have a bypass, you look at them endoscopically, their esophagus hardly ever looks damaged. And now there are times it is damaged, and that usually gets to the points that Lena and I were talking about earlier. And certainly a hiatal hernia is not something you should ignore in a patient that you're doing a gastric bypass on. But I would go back to if you have reflux and you have a gastric bypass, it's probably something, to use Lena's term, related to the morphology of the operation, or something that's occurred related to that, and that's what we need to address. And so I'd hope if you scoped all my bypass patients, you wouldn't say 80% of them have a hiatal hernia.
I like to add, Barham, if I may, you know, you're going to be attacked by us, so I'm going to add something. So I will say that what people forget, and this is because we surgeons will never admit this, I think when you see the dissection that some of the surgeons do in the hiatus to do the bypass, we are the one who creates those numbers that you have. If you do a bypass in a patient without a hiatal hernia, or you do a bypass with a patient with a small hiatal hernia, and you don't do this crazy dissection, the numbers are very close, very small. The numbers will be between 3 and 6%. But when there was a group or a lot of group trying to teach you for the sleeve, especially more, you need to dissect everything, bring all the fat there. You create that hernia, you create the problem for the future. So I would say, to be fair, you should expect bypasses from 6 to 7% of problems with GERD, compared with up to 25% with the sleeve. But in our experience with the sleeve, that we don't do sleeve in patients with significant reflux, and we pay a lot of attention, what Lena mentioned, that it probably is one of the most important things, the shape and how you do it. Our incidence of reflux is 2% in the sleeves, and we're talking 4,000 sleeves. So I think the technique in our case will have a lot of implication.
One preface I would have to say, I'm not saying that 80% develop reflux. I'm saying incidental finding of a lax anti-reflux valve or a hiatal hernia, that I agree with Eric and Jonathan, that it's most of the time it's trivial finding with that patient. That means it's not clinically relevant. So I agree with that comment. And the preface was the incidental finding, not reflux. We have a couple of more minutes and we have to wrap this up. Any final burning comments?
I think this was a great session, Barham. And thank you so much to all the panelists. This was a great discussion, and we've been talking about this a lot lately on a lot of national forums. We hope to continue on our discussion on the AFS Doc Matter discussion site. We had a lot of great questions and we couldn't even get to them all because we had so much to talk about. And I think all of us are passionate about this topic that we could probably talk for a whole day. So thanks again for all the participation, and look forward to seeing you all soon somewhere.
Thanks, everyone.
Thank you.
Thank you.
Thank you.